Yeah, good afternoon, everyone. So today we will discuss few cases of autumn 2017. So we go to the cases. So the first case is female 60-year with a lesion in the kidney. The lesion diameter was given 17 millimeter in the right kidney, and the surgical during the surgical excision, the mass was disrupted. So we have the representative section. So this is a section from our low magnification. We can see the lesion is well circumscribed and the ink margin is visible. The lesion is quite away from the ink margin. And if we move closer to the lesion is showing actually tripartite appearance. There are areas of mature adipocytes. Predominant of the lesion is composed of spindle cells, and few of them having a kind of epithelioid appearance. And there is also a conspicuous blood vessels. If you move around the lesion, there is also another areas which is showing the same repetitive pattern of admixture of mature adipocytes, spindle cell, as well as the blood vessels. The blood vessels are elastic lamina deficient, and the lesional cells are oriented uh, almost perpendicular to the adventitia. This is known as hair on end appearance of the lesional cells, which is very characteristic for renal angiomyolipoma. If we move around, the cells are showing bit atypia over here and there, but there is no increased mitosis or necrosis. There are some lesional sclerosis, band of collagen. So this is a straightforward case of renal angiomyolipoma. And obviously, you should examine the adjacent or neighboring kidney. The neighboring kidney is mostly unremarkable. The glomeruli are almost normal. The interstitium and the tubules are also normal. So you go on to the diagnosis that this is the renal angiomyolipoma, and this is a normal variant. There are other few variant like fat core variant and etc. epithelial variant, and you should say in the further workup that we will do further uh, leveling as well as sectioning from the lesion, just to say any area, high grade area, or exclude any areas of epithelial morphology. There is no as such recommendation for the cutoff of epithelial area, but you can say that many are literature, they have seen the 10% epithelial area heralds a poor prognosis, and epithelial angiomyolipoma, even though it's a classical morphology, can be seen metastasizing to the lymph node, but it doesn't have a bad prognosis, even though it is found in the regional lymph node. In the further workup, apart from further sectioning, you must say that this lesion is known for both smooth muscle phenotype as well as the melanocytic phenotype. So this marker like HMB45, melana, as well as SMA, they are positive, and you can mention the SMA is also positive in the mature adipocytic element. You also say you will revisit the gross to denote the centricity or multifocality, because renal angiomyolipoma, if it is multiple, then it has an increased propensity for syndromic association like tuberous sclerosis. So in the further sectioning, further workup, this is how you complete the further workup. And in the remark or additional info, you can say mostly it is sporadic in nature, and as this lesion was, and in syndromic association, the tuberous sclerosis, they are multiple in nature. They have some other lesion like pancreatic cyst, renal cyst. There can be pulmonary lymphangioma, CNS tumor. These are all part of the tuberous sclerosis syndrome. And in few of the sporadic cases also, there are genetic mutation of TSC1, which is a tumor suppressor gene. And usually it is a benign lesion. They are incidentally detected. And if it is large enough, they are having an increased chance of retroperitoneal hemorrhage. And in that case, the patient will present with pain, abdomen, and acute presentation. So this is how you complete your answer. Okay. Now moving on to case number 2, which is elderly female, 73 years, presenting with a single duct nipple discharge. So the age and demography is quite suggestive of a lesion. So we have the representative section from the lesion, which is kind of inked from the periphery. So this is a kind of excision many of us are aware of. So this is a microdocectomy specimen. And if we see the lesion from the lower magnification, we can see uh, uh, actually the ducts which are dilated, and there is periductal fibrosis. Few of the TDLU, they are showing this kind of increased cellularity. And if we move around, the most of the ducts are dilated and they are having inspissated secretion. Lobules or ductular spaces, they are surrounded by inflammatory cells. And intraluminal also, there is collection of few granulation tissue-like element over here. And also in other bits, yes, this is other bit. There is a few papillary projection into the lumen, and there is also granulation tissue. There is a bit denuded epithelium over here, and macrophage and lymphocytes are the predominant inflammatory cells. They're seen in this lesion. And this is a old lesion because of this is a well organized fibrous lesion in the periductal location. So and in the lobular unit, you can say that epithelial hyperplasia is seen. This is the epithelial hyperplasia. We can see the spaces which is mainly centered towards the periphery of the ductule, and they are kind of crescent shaped. They are parallel with the outline of the lobules. So this is a usual type hyperplasia. And another point is that there are biphasic appearance. There are lobular cells also. There are myopithelial cells also. So you can differentiate between the biphasic population. And the main lesion, this is the microdocectomy specimen. So this is a specimen of duct ectasia. So duct ectasia is actually disease of perimenopausal or elderly age group, even though it can occur in the younger age group also. And the pathophysiology is like that. It is involution of the ductular unit, and there is uh, obstruction and inspissated secretion, which can be seen. Is that the secretion within the ductular space, and as it goes on, this has actually active inflammatory phase, which is characterized by influx of lymphocytes as well as macrophages, as well as when the lesion organizes, it undergoes more fibrosis. So these are the area, another area of usual hyperplasia and scattered lymphoid aggregates, and focal element of fibroepithelial lesion is also seen. So this is a duct ectasia. There is no evidence of in situ or invasive malignancy. In the further workup, you can say you will evaluate deeper levels and every beats from the lesional lesion to exclude any possibility of in situ or invasive malignancy. In further information, you can say that this lesion is known to occur in the perimenopausal or in the elderly age group. You can say about the pathophysiology like this. So this is a kind of straightforward question, and it is a low scoring question. So just to not to be moved away with the epithelial hyperplasia and in situ component, they want to see to that the candidates actually are confident enough to denote that this is a benign entity, and they know that this is a specimen which is commonly occur in this clinical demo setting. Okay. So if you have any questions, you can put in your in our YouTube chat so that later on we can answer them one by one. Moving on to case number 3, this is a 64-year male patient with a history of stem cell transplantation and with a recent history of rash, which is kind of suggestive of bullous or pemphigoid in nature. So this is a skin punch, which is having 2 beats. One beat is non-bullous, but you can see the follicles are affected. There are some changes in the follicles, and there is some apoptotic cells in the follicular infundibulum. And if you go onto the vasculature part, you can see this is a quite a significant of vasculitis, amount of vasculitis is going on, and in few of them there is also leukocytoclasia is going on. So all these are part of this lesion. And then moving on to another bit, and if you concentrate on the cellular feature, there is acantholysis, there is multinucleation, there is molding. So this is a multinucleation, molding, and this is very 3M for varicella infection. Okay, so yeah, so the 3M stands for multinucleation, molding, and margination of the chromatin. Okay, so this is a quite characteristic for varicella or herpes family infection. As the patient is having a clinical history of stem cell transplantation, so clinically there is the patient is having immunosuppressive drugs, so that have actually perpetuated to the clinical condition. So you can say that in the further workup, you will look for the specific immunohistochemistry which is available, and the varicella zoster immunoglobulin. If it is stain, it stains that cells that it is suggestive. Another way of making the diagnosis is the viral PCR from the bullous lesion. So that can be done in the clinical setting. So this is how you confirm your diagnosis. In the further information, you can say that in the remarks that varicella zoster is kind of opportunistic, or it is a revival from the sensory ganglia from the latent infection. It travels to the nerve root and affect the specific the dermatome, which is very painful. Clinically, it presents with the papule, or sometimes it's arterial lesion, and in some cases it can be a bullous lesion also. And in if it is affecting the 7th or 8th nerve, then it is quite painful. Then it affects the external auditory canal. It can affect the ocular division. Then patient can have a complication of blindness as well as otalgia, this kind of. And there is a syndrome known as Ramsay-Hunt syndrome, which is associated with this complication of 7th and 8th of motor ganglia cranial nerve involvement. So this is how you say the further information and complete your answer. So follicular involvement. So how to differentiate it from the simplex infection, herpes simplex infection? Herpes simplex will never affect the follicular part, and the leukocytoclastic vasculitis will be absent. These two features helps to differentiate between the herpes simplex from the herpes zoster. But obviously, the diagnosis made after PCR as well as from the after performing an immunohistochemistry on the section. Case number 4 is a 61-year female patient, and patient having a solid and partially cystic mass of 80 millimeter. The patient is a post-menopausal age group, 61 year of age. So we can see this is a solid part of the lesion, this is a cystic part of the lesion. So if we move on to the solid part, this from the lower magnification, it gives a nodular appearance. So individual nodules or lobules, they are separated by fibrous septa, and the septa is also having this kind of cellular component which is plumb to spindle, and they are gradually acquiring more amount of cytoplasm, and there is component of clusters or nodules of clear cell, which is suggestive of luteinization. And if you move on to the less cytoplasmic area, this cells is plump. There is minimal or very it is not that spindly that we see in case of fibroma cases, but they are kind of plump to ovoid in nature. And gradually, if you move on to the luteinized area, obviously they gain some clearing in the cytoplasm as well as clearing in the and increasing the cytoplasmic volume. There is no necrosis, no atypia per se. Okay, and there is no increased mitosis also. So this is a impression which can give you a sex cause stromal lesion. You can favor a diagnosis of luteinized thecoma because the thecal cells you can compare with the normal thecal part, which is kind of this is actually the classical thecal part, and which we see in case of any follicular cyst, and this is the luteinized part. So this is the luteinized thecoma, and you can say this is in your further workup. To differentiate it from adult granulosa cell tumor, which is more common in this age group, you can do a reticulin stain. In reticulin stain, adult granulosa cell tumor will show the clustering phenomenon. That is, all the lesional cells, they will be wrapped around by reticulin clusters, and all other sex stromal tumors will have a individual cell wrapping, that is the pericellular reticulin staining pattern. So this is the importance of using reticulin, and it is appreciated in any exam. And in immunohistochemistry, these lesional cells are positive for inhibin, SF1, and FOXL2 IC, which is also positive for calcitonin, and they are negative for EMA and CK, which differentiate from other surface epithelial tumor or any metastatic lesion. So, and in further information, you can say that mostly this thecal neoplasm or thecoma or fibrothecoma, they present with hyperestrogenism, and the patient will have a atypical uterine bleeding after menopause, and sometimes they have a endometrial hyperplasia as well as endometrial carcinoma also. So you can suggest a endometrial scanning, radiology, or a curative should be done to exclude any foci of preneoplastic condition. And this is a completely benign, even if it is any of large size. And you in one point you can say in the further workup that you will do further sectioning just to exclude any minor component of adult granulosa cell tumor. If it is present, then you can say thecoma with minor component of granulosa cell tumor. If it is more than that, then it is a mixed tumor. So this is how you can classify after further sectioning. Okay. Now moving on to case number 5. This is a female 45-year patient with a rib fracture. So there the section has been given from the fracture site. So this is one of the bony case. FRCPath actually doesn't give any bone tumor per se, and this is one of the exception, you can say. So we can see multiple fragment from a lesion, which is having a two component. One component is uh, diffusely spindle or component, and there is another component which is irregular bony trabeculae. Sometimes it is referred to as Chinese letter pattern, and there is no active osteoblastic rimming. So the rimming, it can be focal, but it is not that active. And there are few this calcified mineralized area, which is quite characteristic for this lesion. So you can expect some areas of mineralization and junctional line, which is present in any case of old lesion. So this kind of junctional line you can see. So this is a biphasic pattern, and this is quite characteristic for fibrous dysplasia. So fibrous dysplasia, you can say that it is a lesion. It can affect any part of the osteoarticular system, and mainly it affect the long bones, predominantly in the long bones and articular joint like knee joints. Okay? And there is you can hardly do any further workup in this case because IHC doesn't help. On one thing you can say that it is mainly CK positive and CK negative, just to exclude any possibility of carcinoma per se. And this is a condition because of a pathological fracture of that lesion. Okay. So this is how you frame your further workup. And in the remarks, you can say this can be polyostic and monoostic. And monoostic is more common than the polyostic variant. The monoostic variant have usually a genetic basis of GNS1 mutation, and it is more common in the female, as our case is. So these remarks you can give, and in other line, you can say that the differential can be osteofibrous dysplasia. In that case setting, the irregular bones or these haphazardly arranged bones will be lined by active osteoblast. The lesion becomes osteofibrous dysplasia, and in that case, the lesional cells will be positive for CK. So this is one helpful immunohistochemistry you can use to differentiate from osteofibrous dysplasia. Okay, and if it is of low age, then it's clinically can be of syndromic origin, mainly polyostic, and in that case, Mathune-Albright syndrome is a possibility. So the workup can be directed towards that one. Okay. Now, moving on to case number 6. This is a 31-year female patient. Patient was detected to be a multinodular goiter and now underwent total thyroidectomy. A section was given from the right lobe. So we have a section from the thyroid gland, which is showing variable areas of lymphoid aggregate, as we can see here. Apart from that, we can see two areas which is quite cellular and different. So there are areas which is having a papillary configuration, and there are presence of classical nuclear feature of papillary thyroid carcinoma. So there is cellular overlapping. There is open and that is salt and pepper chromatin. Nuclear grooving we can see. So this is a quite classical picture of papillary papillary carcinoma, thyroid carcinoma, and there are multifocal presence. So this is not a single foci. There are another foci also. Okay. As you move along, there is another foci also. Mhm. Yes, here also there is another foci of PTC, and this is a classical papillary carcinoma. And also the background is showing lymphocytic thyroiditis. We should mention that there is bit of formation of the lymphoid follicles here, and there is presence of follicular destruction by the lymphocytes. So the background is having a feature of lymphocytic thyroiditis. Yes, there is another foci of papillary carcinoma. Okay, so this is a multifocal papillary carcinoma of the thyroid, and it is mostly incidentally detected. You can refer to any previous cytology just to have any kind of B3 category whether given. So this is one important workup you can do, and obviously you can do further leveling as well as further sectioning from the lesion. Just to determine the highest area of tumor size, and the PT stage will be determined based on the tumor size in that case. Multifocality is already proven, but multifocality is not actually a poor prognostic factor. The tumor stage and prognosis depends on the T size and the T stage actually for any thyroid differentiated thyroid tumor. Okay, and just to refer few of the data set, you need to say that it is a well differentiated thyroid tumor, and you are excluding any area of necrosis, you are excluding any areas of higher mitosis. You can take a help of Ki67 in that case. And obviously the other areas like it should be noted that there is no angio invasion, lymphatic invasion, perineural invasion. So these are the common data set point you need to mention when you are having a dissection specimen per se. And you say that is the multifocal papillary carcinoma of thyroid. And obviously the region is well excluded, as we can see the margin or the ink margin is devoid of a lesion. So in further workup, you can say that you will discuss this case in the endocrine MDT or head neck MDT, and you will take out any history of previous radiation, particularly whether there was any previous lymphoma, history of lymphoma or something that for that neck was radiated. So this kind of correlation will be appreciated in the exam. So this was a case of multifocal papillary carcinoma of thyroid. Okay. Now this is a interesting case. So this is the case number 7 with male 66-year of age, and there was a diffuse parenchymal change and a video assisted thoracoscopic biopsy was done from the lung. So from the lesion, we can see that this is a quite a cellular lesion, quite a giving a basaloid or very cellular look from the lower magnification. And if you go on the higher power, we can see that this lesion is kind of nodular appearance. This is a blood vessels, and this is a cartilage, which uh, designate that is having kind of central airway disposition of the lesion. Okay, and the lesion is lobular in appearance, and they are separated by fibrovascular septa. Okay, so this is how the tumor is. And if you go on higher magnification, the cells are quite monomorphic. They are having a size of small or mature lymphocytes. And the vessels, there is angioinvasion. The cells are monomorphic, are very mature in looking. And there are areas of few clear cell which you need to look at, because this kind of lesion usually have a area of monocytoid B cell. Not able to find it right now, but usually they happens. Okay, so this is a monomorphic, very low grade lymphoid neoplasm. And this is a quite a significant area of involvement in the pulmonary parenchyma. Okay. And if you move on to the periphery, there are also areas where the lymphoid cells, they have spilled over to the adjacent alveoli. Okay. And in few of the cases, you can get a lymphoepithelial lesion also, mainly by here it will be there. So the cells will, the alveolar spaces will have the lesional cells. Is not actually opening up properly. So the alveolar lining will have the lesional cells. So there is a lymphoepithelial lesion. Yeah. So this is the alveolar lining or septa where the lesional cells are encroached. So this is area of lymphoepithelial lesion. So what we are getting? We are getting a monotonous population of cells. We are getting very low grade nuclei. There is no high grade transformation in this case. And there is lymphoepithelial lesion, there is angio invasion. So overall, it is in favor of lymphoproliferative lesion. You suggest that in the setting of a lung, you favor a low-grade lymphoma, specifically the extranodal marginal zone lymphoma, because that is the most common lymphoma, low-grade lymphoma that is happening in this particular organ. And you say that you will do further sectioning to exclude any area of high grade transformation, because in in few of the area, if it is more than 20% area that is showing a high grade transformation, that is actually prognostically poor. And if it is in a local pockets or in local zone, that can be subjected for further evaluation, because marginal zone lymphoma can have a certain immunoblastic or centroblastic variation. So if it is a significant diffuse or more than 20% of the tumor area having a large cell transformation, then you can say this is a DLB cell transformation. And your further workup will be designated for excluding a high-grade transformation. And obviously, you will exclude other possibility of benign or precursor lesions. Okay, so you can do a monoclonality testing. You can do if it is a kind of borderline, you can suggest immunoglobulin heavy chain rearrangement study for clonality assessment. And obviously, the marginal cell will show the CD20 positivity, and other marker will be of no use in case of marginal zone lymphoma. So this is kind of wastebasket, and this is how you will work up this case. And ultimately, this case will be referred to the hemato-oncology diagnostic center. And you say that the external marginal zone lymphoma of the lung usually associated with some autoimmune disease, mainly Sjogren, rheumatoid arthritis. So this is the common association that can be found in external marginal zone lymphoma. And you say that this external marginal zone lymphoma is staged depending on whether it is lung confined or it is spreading towards the nearby lymph nodal zone, whether it is a hilar lymph node, mediastinal lymph node, then and chest wall or diaphragm, then it will be stage 2. If it is abdominal lymph node or extra pulmonary involvement, then it is automatically becomes stage 3. So this is how they are staged, and obviously the DLBCL component will have a poor prognosis. So this is how you frame your script and answer this. And never forget to discuss this case in the hematolymphoid MDT and refer the or thoracic MDT, and ultimately this case will be referred to the HMDS. Okay. Case number 8 is male 60-year patient with a history of alcoholism, and he underwent emergency laparotomy for acute abdomen. So at laparotomy, there was a ischemic segment of the small bowel which was resected out. So this is the section from the small bowel, and from the lower magnification, we can see it is showing a ischemic pattern of injury. The surface epithelium is completely denuded. There is no there is no chronicity in this. There is no fibrosis or altered architecture, particularly in this section. So all the mucosa is being sloughed off. There is significant amount of hemorrhage. It is top heavy kind of appearance, which is significant for acute intestinal injury, ischemic kind of injury. And the thing is that the vessels are dilated. And if you zoom in and go on to the higher magnification, you can see this fungal organism, which is non-septate and broad ribbon-like hyphae. So they are infiltrating the vascular space. So this is a quite characteristic for angio invasion. And so this is a ribbon-like hyphae, which is characteristic for mucor. So because it is having a angio invasion, so it is systemic by now. So once you are detecting this angio invasion and mucor, so it becomes a clinical importance. You need to notify the fungal organism as quickly as possible to the clinician, because they are going to start the treatment for this case, number one. Number two, that is the first thing you should do. Number two, after confirming, after that, you should to confirm the fungal lineage. You can do a PAS and a GMS just to highlight that it is a fungal organism. And you can refer to molecular microbiology for PCR diagnosis of the species. So mucor is actually a opportunistic or infective organism which occur in many a setting. Like the patient is known alcoholism, so he must be having some underlying immunosuppression, liver disease, or other conditions like diabetes. And we all know the COVID infection. These are the all risk factor for mucor infection. And you can say that the prognosis depends on the clinical status. If it is having a multiple organ failure, like patient is having already liver or kidney affected, then it have a poor or guarded prognosis. Patient should be immediately taken up for systemic therapy for further management. And this clinical notification you must not miss for particularly for this case. Moving on to case number 9. This is a female 45-year patient, and a loop biopsy was done from the cervix. And there was a history of HPV positive cervical cytology, and there was recurrent borderline change on the cytological evaluation. Okay. Now we have this cervical biopsy. We can see that this is actually two part, you can say. One is bit exophytic over here. So exophytic over here, and there one is more flat kind of lesion. So in this flat area, we can see there is a nuclear atypia, and it is a full thickness nuclear atypia. Mitosis is seen even at the top region. Okay, so this is a CIN3 kind of lesion, and few of the glands, they are involved by the CIN over here. These areas, the glandular involvement of with the CIN. And in this part, we can see this is a more exophytic in nature, and the lesion is having a viral cytopathic changes like binucleation. These are the viral cytopathic effect areas, and this is more exophytic. So this is a area of condyloma. This is different looking from that of the sorry, that of the more basaloid looking area over here. So condyloma is exophytic lesion which is happening over here, and this is area of CIN. So this is a mixed diagnosis or dual pathology. You need to mention it both. You cannot leave the condyloma area or the exophytic area per se. Uh, and you say that what you will do further leveling just to exclude any area of deeper invasion. Number one, you will correlate with the cervical screening and the HPV serotype. It is expected to be a positive or high risk group. And in the morphology, we will just corroborate with a P16IHC. So this is those two important steps you must mention. And you say that HPV is the risk factor and for cervical carcinoma, and the lesion is reaching up to the ink margin. So whatever the surgeon have done, you need to discuss it into the gynec MDT, because seen at one of the ink margin, and there is no actually invasive carcinoma. So the case can be followed up in the gynec OPD or whatever they think at the MDT. And you say that this is the high risk HPV class, mainly 16, 18, they are expected. And even though this has been established, you can say that HPV, yeah, it can be given the HPV vaccination can be given for further course of management. Okay. Now, case number 10, this is a 38-year male patient with previous history of testicular cancer, treated with orchidectomy, and now small bowel mass has been given. So, one important thing, whenever you are getting history of orchidectomy, usually the patient, if there is any retroperitoneal lymph node, if it is not given, then you should keep a possibility of radiation also, because the retroperitoneal area is treated, if it is there or something is suspicious in the radiology, they treat or follow up the patient with adjuvant radiotherapy. So whatever the case may be, don't miss the clinical clue. Okay, even though there was no evidence of radiation or ischemic kind of change in the bowel mucosa, so the history is important in every short cases. Okay, so this lesion is infiltrative. We can see this mesenteric fat or submuscular fat is infiltrated by this lesion, and this lesion is having a long fascicular arrangement, and there is characteristic perivascular edema, which is very characteristic for this lesion, and this has kind of very long extension into the adjacent soft tissue, and there is a small lymph node with perinodal pericapsular sinuses, which is unremarkable. You must mention it in your answer. So this is a lesion which is quite common and abdomen. So these are the areas where the perivascular edema is quite characteristic, and long fascicles. This is a hypovascular lesion which is very fibro or myofibroblastic in nature. There is no atypia. You can have some mast cell over here and there, but this is there is no mitosis per se. So this is a case of fibromatosis. Okay, so fibromatosis is only very important. Only shows a positivity for beta catenin as well as some few speckled CD34 also. And the differential you must keep in these cases, even though the history and morphology is quite suggestive, you can keep a differential of solitary fibrous tumor, leiomyoma, some neural tumors. So you can put a IHC table, mainly incorporating beta-catenin, CD34, S100, STAT6. So these are the few immunos you can take help of. And you can say that fibromatosis can be associated with some syndrome, mainly FAP. So whether there is any history of any any colon cancer in the family, so that can be screened. And this lesion is completely, if it is completely excised, then it doesn't recur. And that is why it is important to evaluate every bit from the tumor, so that no residual lesion is present in the patient. If it is, then it is always a chance of any recurrence, and it is sometimes very debilitating and very deformative, and often the surgery is not possible. So in the GIMDT, you discuss this after further sectioning and all that. It is a benign, so it doesn't actually have a malignant or a metastatic potential, but it locally kind of very annoying once it is incompletely excised. Okay, and obviously you must mention the association with the FAP and other genetic syndromes. Okay. Moving on to case number 11. So this is a case where actually we are moving close to 1 hour. Just I will like to stop here and take some few questions. Rest of the cases can be discussed in the next session. Okay. So fibrocystic change, Dr. Subhasakti, I think there are element of fibrocystic changes, but yes, you can say that as adjacent breast tissue shows areas of fibrocystic changes as well as usual ductal hyperplasia. But the main lesion is obviously the duct ectasia. Okay, and there is no atypia. But you should evaluate all the section, and you can do multiple levelings. One important thing is in fibrosis in duct ectasia is that radiologically it can mimic a B3, sorry, U3 or U4 in radiology, because sometimes the inspissated ducts, the secretion, they can show microcalcification. And in the section, you need to correlate with that, whether you are seeing a microcalcification or not. And that kind of correlation you must do when you are getting the section. Okay. In multifocal papillary carcinoma, how to stage it? Yes. So, yeah, I mean the T stage. Is it only the largest foci? Yes. So it depends on the largest foci exactly, and you should add the M suffix previous to in your final staging, because it is a multifocal tumor. So you put your TNM staging as PMT, whatever it is, PT1 or something, and it depends on the largest foci of the tumor. Okay, so that is there. And one another approach, it can be like if you are having a multiple foci, all are kind of very close to each other, you can say that this is a various foci have been identified, and the largest among them are these, even though there are other small foci which are measuring this. So this you can mention all the other foci and their dimension, and you can concentrate and you can keep the core data element pertaining to the largest foci, whether they are angioinvasive, they are showing a lymphatic invasion, and all that. So the core data element can be concentrated on the largest T size. Okay. So, Dr. Supraditi has asked, are we expected to differentiate between varicella zoster and herpes simplex virus by histology? You should give that I favor a varicella zoster because I find some histological clue, like there is follicular involvement, there is leukocytoclastic vasculitis, because you know the 3M and the blister are similar for both HSV as well as uh, varicella. So both are similar, only the associated inflammation and is more in case of varicella zoster, and in case of herpes simplex you will not get any follicular involvement. One hypothesis is that as the virus actually comes from the sensory ganglia, and the sensory nerve ending they ends near the follicular at unit, so the follicular units are affected. So one hypothesis is that also. So you favor it, that I favor varicella zoster. I will do a ISC which is very specific for varicella zoster. It will help to differentiate. Uh, so it is expected that you should differentiate between these two. Yes. Okay. Any further question? If it is not there, then we can stop here. We can meet again in the next week for further case discussion. And if you like our session, you please subscribe to our channel, and also you like it in the YouTube channel, so that it can be circulated to other candidate also. Okay. So we stop here, and we'll again meet in the for discussion case 11 to case 20 next week. Okay. Thank you for all for joining and your comments.